So now we're going to look at the top fluid in the ICU trials, the top 10. First trial you definitely have to know is 2001, is the Manning Rivers trial, the early goal-directed treatment trial. So you can see here the algorithm, the famous first you get the CVP, 8 to 12, and then you focus on getting your MAP between 65 to 90. And once you have that, you look at your central venous oxygen saturation. If it's less than 70%, then you transfuse. If the hematocrite's less than 30%, or you give inotropic agents if the hemoglobin was fine. And the early goal-directed treatment reduced in hospital mortality from 47% to 31%. That launched the early aggressive resuscitation era and the surviving sepsis bundles, but we're going to see how it was debunked later on because of changes in patient care. The next two trials to definitely know are the SAFE trial and the VICEP trial. SAFE trial, 4% albumin versus saline for fluid resuscitation in the ICU, 2007. ICU patients requiring volume resuscitation. And you can see the only 18% septic shock patients. There was no mortality benefit in the general ICU population. Safety concern for albumin and traumatic brain injury patients. It started the albumin conversation in traumatic brain injury. Saline likely to remain standard of care. So in the septic subgroup, it seemed like it was better with saline, but it did not cross 1. Then came the Albios trial in New England Journal of Medicine 2014. That was severe septic patients, unlike that SAFE trial, which only looked at 18% septic shock patients. This is patients that were severely septic, and there was no 28 or 90-day mortality benefit with albumin combination. Crystalloids alone remained the standard of care for sepsis. Of note, in the Albios trial, the severely septic shock patients did seem to benefit. And there was a benefit in terms of overall getting off of pressors. You were 1 day less on pressors. The Albios trial was also given with 20% albumin. It was basically 300 cc's of 20% albumin every morning, and the goal was to try to get your albumin level above 3.0, as opposed to bolusing, a 250 cc 5% albumin, as what we normally do when somebody's hypotensive. So you have to understand that. The VICEP trial was Hespan versus Ringer's lactate. This is where in 2008, at that time we were using Voluven a little bit in the hospital, and it was thought that the hetastarches could be a great colloid, and in fact it increased your AKI and R and renal replacement therapy. So that's when the hetastarches really fell out of favor in 2008. A couple trials, but the one you should know is the VICEP trial. So then you have the early goal-directed treatment trilogy that came after the Manning Rivers trial. By this time, early antibiotics, early fluids have already been adapted. So that's the caveat to saying that the process, ARISE, and the PROMISE trials were negative trials in terms of showing that a protocolized algorithm benefited septic shock. So basically, there was no mortality benefit of protocolized CVP SVO2 guided early goal-directed treatment versus usual care. Meaning, if Ari Cement as an intensivist goes to the ICU and sees a patient hypotensive, I would say, okay, let's give a 30 cc per kilogram bolus. Let's give fluids, antibiotics. That was just as good as if I put a central line in, looked at the CVP, then looked at the MAP, then looked at the SVO2 saturation with a protocol. So that shifted the focus to individualized resuscitation. The mortality was about 18 to 30% across the trials. Remember, in the early goal-directed treatment trial, it was 45% in the non-protocol therapy group and 31% in the protocol group, period. So this is clearly a benefit that was not replicated in the process ARISE. The ARISE was in Australia and New Zealand, PROMISE is in the UK, and process here in America. And now we have the key studies of the balanced electrolyte solutions versus saline. So we have the SPLIT trial, which was paved the way for larger trials. That's why I left it here. JAMA 2015, no difference in AKI or mortality, neutral safety signal for the balanced fluid. So then the SALT ED, balanced crystalloids versus saline, showed overall MAKE 30, which is basically need for RRT, mortality, and persistent renal dysfunction. Those are the 3 categories of MAKE as new RRT, death, persistent renal dysfunction by 30 days. If that was less, it was less, 4.7% in the balanced versus 5.6% in the saline. So it seemed that saline increased kidney injury. So then came the SMART trial, which is the only positive trial in terms of balanced crystalloids versus saline. 15,800 ICU patients. There was a lower MAKE 30 with balanced fluids, 14.3% versus 15.4%, p-value of 0.04. The reason why people got excited is because the sepsis subgroup showed that the mortality was 26% in the balanced group versus 31% in the saline group. So it seemed to say that the septic subgroup did better. So that's the most practice-changing crystalloid trial. Helped shifted ICUs to lactate Ringer's plasma-lyte. The BASICS trial subsequently did not show any mortality benefit overall. In fact, there's a little mistake there. It says saline harm in TDI. No, it was plasma-lyte harm in traumatic brain injury, perhaps. So BASICS trial basically negated the SMART trial, and then the PLUS trial, which is another New England Journal of Medicine trial, 5,000 ICU patients. There was no difference in 90-day mortality. And so coupled with the overall analysis, the overall message is balanced crystalloids are reasonable, but benefits are modest. And that's the story. So you should have split salty D, smart, basics, plus trials in terms of your balanced electrolytes versus your. Then what you have is the classic trial, which is restricted versus standard IV fluid strategy after initial resuscitation. So after you get your 30 cc's per kilogram bolus, should you use restrictive fluids or should you just keep on giving 500 cc's, another liter of fluid? So restrictive fluid strategy did not increase 90-day mortality and reduced fluid balance. So the idea is that actually this supported limiting fluids after the initial resuscitation. So this is called the de-resuscitation concept. Classic trial in New England Journal of Medicine 2022 is one of the top 10. And then to round it out, we have the Clovers trial, which is early vasopressors, so early leave-of-ed basically, plus restrictive fluids versus the liberal fluid strategy 2023, New England Journal of Medicine, early septic shock patients in the ER and ICU. There was no significant mortality difference. The early vasopressor strategy decreased total fluid volumes without harm, establishes the safety of early norepinephrine and fluid-sparing approaches during the initial resuscitation. Honorable mention is the Fresh trial, CHEST 2020, passive leg raise, and stroke volume guided fluid responsiveness, the strongest randomized controlled evidence, supporting dynamic fluid physiologic assessment to avoid unnecessary fluids. And this is an excellent concept to teach others, but basically we shy away from static measures, which is just following up wedge pressure, for instance, following up CBP for sure. And now we use passive leg raise, stroke volume. That would be the Fresh trial in 2020. So overall, the takeaway message is you start resuscitation promptly and then you reassess continuously. 30 cc's per kilogram is a starting point, not a fixed target. We looked at balanced crystalloids being preferred, for the SMART trial and the salty D, but then the absolute benefit is really modest. The subsequent meta-analysis don't really show any clear benefit of balanced crystalloids, and that is on the heels of the basics and the plus trials. We definitely should avoid hetastarches, given the VICEP and the AKI problems. The albiose and the SAFE trial did not show any clear definitive evidence for albumin over normal saline, although in really severe septic shock, it's typically what we use, especially if the albumin is lower than 2, try to get it above 3. Early goal-directed treatment protocols, not routine after the process arise promised negated the Manny Rivers trial, and then early vasopressors, restrictive fluid strategies as per the classic/Clovers, and we should use dynamic tests as per the Fresh trial.